Hi, my name's Tippett. I'm an infectious diseases consultant and research fellow at the Burnet Institute. I have a conflict of interest, which is that Pfizer provides funding for education for GPs in Australia. To compare Australia to the US, so the actual land mass of Australia is not that much smaller than the US, so it's a big country, but the population is about 1/10. And that population is concentrated on the east and the west coasts of Australia, with not that much in the middle, except for scattered small towns. And so this provides a lot of challenges to providing care to people in Australia. In terms of how Australia experienced COVID compared to the US, this is per capita cases in the US, and so the US did experience several waves, whereas Australia managed to keep COVID more or less under control until the population was about 90% vaccinated, so that was pretty good. The biggest outbreak was Omicron, so the majority of Australians were affected with Omicron. The current long COVID situation is estimated about 3% of the population, which is 800,000 Australians. And the healthcare strategy after a long COVID government inquiry is to embed long COVID care into the existing primary care chronic health pathways, which are already stretched to bursting, and this just isn't working. There were initially 6 publicly funded long COVID clinics. It's now dropped down to 2, and as far as I understand, these 2 do not offer any off-label prescribing. So my interest in long COVID developed after establishing a staff clinic to care for nurses who were infected with Delta during a large hospital outbreak, and 6 months later, most of them were still infected. So the writing was on the wall about how severe the long-term consequences of long COVID were going to be, and that the government wasn't really putting anything in place. And so I was very comfortable with telehealth at the time through the pandemic, so started Clinic 19 as a telehealth service, providing care to anybody in Australia because of the access via telehealth. Particularly interested in low-dose naltrexone at the time. Within 2 months of letting the long COVID community know that there was a physician who was interested in long COVID, I had more than 200 people on my wait list, and so quickly had to recruit more doctors into the clinic, including paediatrics. The principles of long COVID is that, the principles of Clinic 19 is that long COVID is a biomedical disease, and so we offer medications. We don't recommend CBT or graded exercise therapy. We, much like the previous presenters and some of the posters have identified, we use a lot of off-label medications, and every patient gets assessed for sleep disturbance, fatigue and POTS, an absolute minimum, and every other symptom that comes through, as well as a COVID action plan and any other support that they need. I think by working in this model, we've worked very closely with our patients through therapeutic experiments, and so through patient feedback and pooled experience, we've expanded our therapeutic model and our repertoire of medications that we use for people with long COVID. We've seen 1,300 people across Australia, with 70 of them being less than 16 years old. As far as I know, we're the only long COVID service providing care to paediatric patients at the moment, and that's all on the shoulders of predominantly one paediatrician, Michelle Schooler. Much like the international data, the mean age of our patients is about 45 years of age, with 75% of adults being female. However, the gender balance for paediatrics is about 50-50. Most of our patients can develop long COVID following the Omicron infection in 2022. However, we are still seeing cases coming through as we expect, and so this problem is not going to go away. Most of our patients are quite severely affected, so post-COVID functional scale 3, which means that they can do their ADLs, but they're restricted in most of their activities, and almost all of our patients have their work affected in some aspect. So there are strengths and weaknesses of this model. It's a low resource model. I mean, I started this by myself. I do not have nursing staff. In terms of running it, it's myself and one practice manager. But the biggest strength is the telehealth model. So The telehealth allows people who are severely affected with long COVID to attend appointments. We all have patients who can't sit in a waiting room, let alone travel interstate to access a specialist service. And so the telehealth brings the care into the patient's home. And long COVID is very suitable for telehealth in that quite often people examine completely normally. You very rarely need to physically examine a patient. And it overcomes the geographical barriers of Australia. On the flip side, telehealth has meant that I have been able to recruit as many doctors as I have. At various points had up to 18 now, 15 regular doctors. And I can easily scale that up depending on my capacity because telehealth provides the doctor with flexibility. So most of my doctors either have young children or they're doing PhDs and they need to be able to flex their work up and down rather than having to commit to a regular clinic. Having as many doctors as we do means that there's a community of practice. I can reach out and ask my doctors, how do I start a statin? Haven't done it for 5 years, can you help me with this? And that also means that when a patient comes to us and says, I hear that this is being used in a clinic overseas, I would like to try it, we can turn to each other and say, have you heard of this medication? Have you used it before? What do you think? And that gives us the confidence to be more experimental in our medication. And with that, working outside of the public system also means that we can be more flexible and more experimental. But there are weaknesses. Telehealth is not perfect. Sometimes you do want to examine a patient. This model does have a fee, so it inherently excludes people who don't have the financial resources to pay for the appointments, as well as any cultural or communication issues. We have less resources to pull on, and we're always, it is a clinic that needs to bring in money. But besides that, we do have a lot going on. There are a number of academics within the group, including myself, and so we've spent the last couple of years designing a pilot and adaptive platform clinical trial, which unfortunately wasn't funded. But if anyone has a spare $4.5 million, Michelle and I would love to hear from you. And we have a bunch of other research activities going on through the Burnet and through the clinic as well. So I asked our patients, what's the most important part of the care that they receive at Clinic 19? And as you would expect, the most important part was having a doctor who knows about long COVID. They don't need to prove to us that they have long COVID. They don't have to educate us about what long COVID is and what people are using for therapeutics and what POTS is and things like that. And that still happens. A lot of the GPs are only just becoming aware of POTS. So that is by far the most important thing. But the second most important thing that the patients reported is the willingness to experiment and provide off-label in a disease that's new and does not have any guidelines, does not have any clinical trials. And that's just what we need to do if we want to help patients. So I'd like to acknowledge my team and the patients who helped.